Hello, my name is Jonathan Finoff, and I'm going to be talking to you about sports ultrasound. I don't have any relevant disclosures related to this presentation, but I do have a disclaimer. This presentation is not meant to be a comprehensive review of sports ultrasound. The objective is to cover the core competencies as outlined in the AMSSM recommended sports ultrasound curriculum for sports medicine fellowships. So please use this for your reference. For this presentation in particular, I'd like to acknowledge Madera Call, who assisted with the creation of this presentation. So I'm going to first talk about what sports ultrasound is, go briefly over the history, the applications, advantages and disadvantages of ultrasound relative to other imaging modalities. Then we'll talk about ultrasound physics, terminology. I'll present some knobology and image optimization recommendations. And then we'll go over normal and pathologic appearance of different tissues and finish off with common artifacts, and we'll draw some conclusions from this information. So what is sports ultrasound? It's a high-frequency sound wave, so these are much higher than what we can actually hear with the human ear. They're between 1 and 18 megahertz. And we send these sound waves into the tissues and they reflect back up and create an image of soft tissues and bony surfaces. And they have unbelievable detail. It's sub-millimeter imaging. It's higher resolution than MRI for superficial structures. And it can be used for a lot of different applications, including looking at tendons, muscle strains and contusions, nerve entrapments, ligament sprains, joint effusions, even foreign bodies, to name a few. And it can also be used to guide interventions, such as injections, tenotomies, aspirations, lavages, tendon and ligament releases, biopsies. Really, you're able to do many surgical procedures with ultrasound guidance. Now, there are different advantages and disadvantages to any imaging modality, and for ultrasound, one of the advantages is that it has the ability to image things in real time. It's a dynamic image. It's a movie rather than a still image. And that dynamic nature allows us to see things that you can't see in a static image. For instance, if somebody has a structure that pops and you get an MRI, you can't see things move, and so you don't know exactly what's popping. And so that dynamic nature allows you to look for stability and instability in different tissues, and is a very nice feature. The other thing that's nice about the dynamic imaging capabilities of ultrasound is it can guide interventional procedures. Since you can see things move, you can guide a needle safely and efficiently from point A to point B to do a procedure. Another very nice thing is that it allows you to interact with your patients while you're imaging. So you perform the history and physical examination, and then you have your ultrasound machine. You can use it to look for specific pathology, and you can talk to the patient while you're doing that image, and you can point out on the screen exactly what's going on, and patients love that. It has minimal metal artifacts, so CT scans and MRIs when you're doing post-operative evaluations can really be skewed by the metal artifact, and it can be difficult to see the structures immediately adjacent to the metal. Whereas with ultrasound, although you can't see through metal, you can certainly see down to metal. And so you can look for peri-metallic abscesses, rubbing of screws that are prominent against tendons and adjacent tissues. So it's very nice from that standpoint. While you're doing the examination, if you see some pathology and you want to compare it to the opposite side, you can just quickly move your transducer over and do a contralateral limb comparison. Whereas that's very, very difficult when you're doing it with MRI. It's also portable, so you can take your ultrasound machine from room to room, but it's very difficult to take your MRI from one clinic to another, so it really is very helpful to have a portable imaging modality. We're talking about tens of thousands of dollars to buy a very nice ultrasound machine, as opposed to hundreds of thousands of dollars, if not millions, for other imaging modalities. So it's relatively inexpensive to buy a machine, and it doesn't expose you or the patient to any type of radiation, and there are no specific contraindications to ultrasound. But just like anything else, it has some limitations. And one of the limitations is that it has a limited field of view. You're essentially looking at a credit card thin slice of tissues while you're doing your ultrasound. And it can't see through calcifications, so it can't see inside of joints, and that limits its ability to look at different bony pathologies. There's also limited penetration. So if you have a very large patient population and you happen to be looking at a structure that's small in the hip, then that might be very difficult because it can't penetrate all the way down to the area that you want to look at. And while an MRI or a CT scan, or even an X-ray for that matter, really takes an image and is interpreted nowadays by a computer generated process, with ultrasound you have to take your ultrasound probe, put it over the structure of interest, orient the probe so that the sound waves hit that structure at a right angle to its surface in order to get the image that you're looking for. And that takes time, and it makes it operator dependent because you have to learn how to do that. But anybody can learn, you just have to put the time and effort into it. Another thing that's a disadvantage to some degree is that they're evolving certification and accreditation standards. So for quite some time, government payers and insurers have been following diagnostic codes to see utilization and to track utilization of various codes. And of course, the codes for ultrasound have really spiked up in terms of utilization in the last several years. And that's because it's a very popular modality to use for imaging. But what that also does is it makes CMS and other insurers wonder who is doing this and what are their credentials. And at this time, we're just starting to have different accreditation and certification standards that are available, but previously there were not. And so if we don't self-regulate, then somebody else will come in and say, hey, in order to be able to practice this and do this type of procedure, you need to have this type of education and this type of accreditation. And so I think it's very, very important to be aware of the evolving certification and accreditation standards and make sure that we are doing the right thing to have adequate training in order to do this modality. And while equipment is relatively inexpensive compared to other imaging modalities, it's not without cost, and so you still have to spend the money in order to buy a good machine. And depending on how much you're willing to spend, you're going to have variability in the quality. So what are the indications for diagnostic ultrasound? I think one of the best indications is when you're looking at a discrete soft tissue structure or region. So if somebody has lateral ankle pain in the area of the superficial tissues, the soft tissues, then that is a fantastic indication for ultrasound. However, if somebody comes in and says, my whole ankle hurts, that's going to be much more difficult for ultrasound because it takes time to image all of those superficial structures around the joint, and you're going to have an incomplete evaluation of the intra-articular structures. So discrete soft tissue structures or regions are most appropriate. Also, if you want to look at something dynamically, you want to see something move, ultrasound is great at imaging these types of structures, so subluxing or dislocating joints or tendons or nerves. Postoperatively, you can, as I mentioned before, you're not going to have the same metal artifact that other imaging modalities are susceptible to, and so they're great for looking at postoperative rotator cuffs, after total hip arthroplasties, etc. It's really nice also for monitoring erosions and synovitis in your rheumatologic patients, and also to evaluate for effusions and to guide procedures associated with joints. In the emergency room, it's commonly used to look at foreign bodies that are not radio-opaque, such as wood and some types of glass. There are no specific contraindications to ultrasound, but if the structure is deep, then it's going to be difficult to image. So if somebody is large and you're looking at a hip, then it might be wise to consider a different imaging modality as opposed to ultrasound. Also, if the structure of interest is deep to something that blocks sound waves, such as a calcification in the tendon, then you're not going to be able to see that structure, and so ultrasound would not be the ideal imaging modality for that. Now I'll talk a little bit about basic ultrasound physics. So in your ultrasound machine, you're going to generate an electric volt, which is going to be converted to a sound wave through the reverse piezoelectric effect when it hits the end of your transducer and strikes a transducer element, which used to be a naturally occurring crystal, but now is typically a man-made substance such as PZT. And there is going to be a preferential frequency of sound wave that's based on the driving voltage, but you will also produce somewhat of a bandwidth. So you're going to have frequencies that are above and below that preferential frequency. So you're going to have a lot of different frequencies coming out from that reverse piezoelectric effect. The driving voltage must be near the operating frequency or resonance frequency of the transducer element to maximize the ability to convert the electric voltage into a sound wave in an efficient manner. Now, a sound wave is a traveling variation in acoustic variables, which include pressure, density, and particle motion. And in order for a sound wave to propagate, you have to have a medium, such as water or gel or body tissues, in order for it to move. If it's in a vacuum, such as in space, you can't have a sound wave. Echoes occur when the sound hits a boundary between two different media. And each media is going to have a specific acoustic impedance. And depending on that acoustic impedance and also how the sound wave strikes, at what angle the sound wave strikes that boundary, that's going to affect how much is reflected and how much sound wave is going to pass through. So from an impedance standpoint, that's the media's density times the propagation speed. And the more alike the acoustic impedances are of two tissues, the less reflection will occur, because essentially the sound wave will think that it's going through the exact same tissue if there's not much difference in the acoustic impedance. Whereas if you have a tremendous difference in acoustic impedance, such as a soft tissue and bone, which have very different acoustic impedances, then most of the sound wave is going to be reflected back. When the sound wave is coming down, if it strikes the tissue interface at a right angle, so it's perpendicular to the surface of that structure, then the sound wave that reflects back is going to reflect straight back up towards the sound wave. Some of the sound wave is also going to pass through, so you have your reflected and your transmitted sound waves. If you strike the sound wave, if the sound wave strikes that tissue boundary at an angle, then some of the sound wave is going to reflect up into the distance, and some of it that passes through is going to get refracted. And all of that is based on the acoustic impedance. When a sound wave hits a smooth, flat surface and it has a perpendicular angle of incidence, it's going to produce a mirror-like or specular reflection. So that's going to be your clearest image. So here's a nice flat tissue interface, and so all of the sound waves that come back up are going to give a mirror-like reflection. But you can also get some reflection when you have a more heterogeneous substance, such as the end of a torn tendon or an abscess. So some of those sound waves are going to reflect back up towards your transducer, and some of them are going to reflect into the distance, and some are going to go out at an angle. But since some does go back up to the transducer, you're going to get somewhat of a fog-like image, and you are actually going to be able to see that. And so it enables imaging of these complex tissues. So the returning sound waves are detected by the end of the transducer and converted through the piezoelectric effect back to a voltage. And that volt is going to be taken back to your base unit, where it's going to be converted to a grayscale image, and that'll form the image that you see on your screen. So the depth of an object encountered by the sound wave is determined by how long it took the sound wave to leave the end of the transducer, reflect off of that object, and travel back up to the transducer. And so this is all based on the standard propagation speed of sound, which is 1.54 millimeters per microsecond. But all tissues have variations, slight variations in their propagation speed. And a pearl is that fat is the farthest from the average propagation speed. It's 6% slower in its propagation speed compared to that 1.54 millimeters per microsecond. And so if you have a lot of fatty tissue, it's going to mess up the interpretation of the image because of the delayed return of that sound wave. When a sound wave comes out of the end of a transducer, it has a specific width, and that beam width is filled with sound waves. The beam will narrow to 1/2 of its width. Everything proximal to that is going to be called the near zone. So here's the near zone. Distal to that area is going to be called the far zone. And the narrowest area is called the focal zone. It has the highest concentration of sound waves, and so that area is going to give you the best resolution of your image. And you can focus using a lot of different things, and the focus is just changing the location of that narrow focal zone. So you can use a curved sound element, you can use a lens on top of a flat sound element, or you can use electronic phasing, which is typically what's used in modern day machines. With electronic phasing, essentially you can make your sound wave closer by narrowing the aperture, by only having certain sound elements send out sound waves. So if it's narrower, then it's going to be closer, focal zone will be closer, and if it's wider, then the focal zone will be further away. Or you can hit the sound elements at a different rate with all of these electric voltages, which can move the focal zone closer or further away. Now you can create multiple different focal zones. So you can have a focal zone that's near, at a mid distance, and then all the way out to a far distance. But the problem is, to create each of these focal zones, you have to send out a specific sound wave, and then you have to stack all of these on top of each other to create one picture. So what that does is it slows down the frame rate, or the temporal resolution of your image, and it'll make the image look almost like you're looking through a strobe light, as opposed to something that's rapidly changing when you move your transducer. Harmonics happen as a sound wave goes through tissues. That sound wave will start changing shape, with the higher pressure portion of the wave traveling faster and the lower pressure portion of the wave traveling slower. And with this nonlinear propagation, you're going to create harmonic frequencies of the original sound wave. And these harmonic frequencies, or new frequencies, are even or odd multiples of the fundamental frequency, or the original frequency. And these are called harmonic frequencies. Harmonic imaging uses a filter that takes out the fundamental frequency and only detects these new harmonic frequencies. And what this does is it allows you to eliminate some of the more superficial artifacts, because those artifacts would develop with the initial fundamental frequency and not with the harmonic frequencies. And also it increases the resolution, because your harmonic frequencies tend to be the part of the sound wave that is stronger. So this is just a visual depiction from Kremkow's book, showing if this is your fundamental frequency here on the left, and these are the harmonic frequencies. If you use a filter to eliminate that fundamental frequency and only detect the harmonic frequencies, then you can eliminate any of the artifacts and also the lower resolution associated with that fundamental frequency. So this is another depiction where you send out the fundamental frequency, which is this lighter gray, and as you go through tissues, you're going to get more and more of these harmonic frequencies, which are depicted by the darker color. So if you were looking at something deep to some ribs, looking into the lungs or looking at the heart, and you used harmonic frequencies, then you would be eliminating some of the artifact associated with the ribs and only detecting the harmonic frequency image that developed later. Attenuation occurs because of the absorption, reflection, and scattering of sound waves as they go through tissues, and that weakens the sound. And this can be quantified in decibels, and since decibels are logarithmic, a 3 decibel change equals a 50% change in the strength of that sound wave. The attenuation coefficient is equal to a reduction in the number of decibels per centimeter traveled, and it's variable depending upon the tissue. Soft tissue attenuation per centimeter in decibels is 0.5 times the frequency in megahertz. And so what that means is that as you have a higher frequency, you have more attenuation. And this is very important, because if you want to look at something that is deep, then you're going to be having a lot more attenuation of sound waves if you use a high-frequency transducer, so you won't be able to see that deep structure. So in order to minimize attenuation and be able to see a deep structure, you have to use a lower frequency transducer. Now moving into some terminology, anechoic means that there's no reflection, so it will be black. So on this picture, this area down here is anechoic. Hypoechoic means that it has low reflectivity, so it'll be darker. So this is anechoic relative to this tissue here, which is a brighter or lighter gray. Isoechoic means that two structures have the same reflectivity, so this is isoechoic to this area right here. And hyperechoic means it's brighter or has an increased reflectivity relative to another structure. So this, which is a tendon, is hyperechoic relative to this structure, which is a muscle. Now we'll go into knobology and image optimization. So the first thing you want to do when you're looking at a tissue is select the appropriate transducer. That transducer should have the appropriate frequency. Almost all of your modern-day transducers will have multiple frequencies or an entire bandwidth of frequencies that are sent out into the tissues. So it might be a 12-5 megahertz frequency transducer. And that means that you're sending out frequencies from 12 megahertz all the way down to 5 megahertz and everything in between. So with higher frequency, as I talked about before, you have less penetration because of that higher attenuation, the higher attenuation coefficient. However, you're going to have higher resolution because of that high frequency. Low frequency sound waves don't have as good of resolution, but they have greater penetration, so you can see deep structures. So in general, if you're looking at something superficially, you want to use a high frequency transducer. And if you're looking at a deep tissue structure, then you want to use a low frequency transducer. Then there are several different endings to the transducer. You can have a linear array transducer, so it's flat. Here's a short footprint or hockey stick linear array transducer, and here's a normal regular footprint linear array transducer. And they send their sound waves in general straight out from the end of the transducer. The nice thing about that is it minimizes an artifact that I'll talk about later called anisotropy. And so it's better for looking at superficial structures and doing diagnostic imaging. But the problem is it has a limited field of view because it's essentially sending out a column from the end of the transducer. So all you see is this column of structures below the transducer. Another type of transducer end is a curvilinear array transducer. So here you can see the curvilinear array transducer. It sends out a fan-shaped array of sound waves. So they go out to the side, they go out the front, and then they go out to the side here. So that gives you a larger field of view. It's really good for deep structures. Most curvilinear array transducers are going to have lower frequency bandwidths. But one of the big problems is it's more susceptible to anisotropy, the artifact that I mentioned before, and so it limits its ability to do a great job with diagnostic ultrasound. So in general, when you're doing a diagnostic study, you want to use a linear array transducer if possible. Once you've selected your transducer, you need to hold it correctly. So if you hold it up high like this, it'd be like holding the end of a pen and trying to write your name. You have very poor fine motor coordination. The other thing is that the interface between your transducer and your surface is really slick because of the transducer gel. So it's going to be moving all over the place. Whereas if you get your hand, your hypothenar eminence, right down on your structure of interest or where you're doing your scanning, and then you hold the transducer right near the end, then you're going to have better fine motor coordination, and you're also going to anchor the transducer and eliminate some of the sliding that can happen. Once you have your transducer over the area of interest, you can glide it or translate it back and forth. You can do a heel-toe maneuver where you dig in one end or the other in order to tip the transducer, and that helps eliminate anisotropy, which again I'll talk about in a little bit. Or if you're looking at something in a short axis, then you can wag or tilt the transducer, again, in order to try to eliminate anisotropy and hit the tissue of interest at a right angle. Rotation is very, very important, particularly when you're looking at a linear structure such as a tendon or when you're doing a interventional procedure. In that case, you want to line up your transducer directly over the top of your linear structure. And sometimes if you're oblique, all you have to do is rotate the transducer a little bit and it'll line everything up so that you can see the structure of interest all the way across the bottom of your transducer. And we use sonopalpation quite a bit when we're doing ultrasound. You can put the transducer over the top of a structure of interest and push, and if that hurts the patient, then you know that you're directly over the area that causes their pain. The other thing is that sonopalpation can help you to differentiate between cystic and solid masses. So if you push on something that is cystic, typically it will be collapsible. It will collapse when you push on it. And if it does have some debris or it's a complex fluid, then you'll see it swirling inside of the walls of the cyst. Whereas if it is a solid mass, then when you push, it might be deformable, so it might bend, but it'll stay the same size overall. So if you did a circumferential measurement, your area would still be the same, and you won't see any swirling inside of it. So that helps you determine whether something's cystic or solid. After you've selected your transducer, you're doing your transducer manipulation, you've found your structure of interest, then you want to adjust some of the knobs. So the first thing that we'll do is adjust the depth, then the focal zones, then the gain, and then the time gain compensation. So the depth knob adjusts the overall screen depth, and what you want to do is you want to line it up so that the structure of interest is either towards the bottom of the screen or somewhat in the middle of the screen. So for example, if we're looking at the median nerve right here, and this is radial, and this is ulnar, so these are muscles superficial to the radial nerve, muscles deep to the radial nerve, or excuse me, median nerve. Here's your median nerve. You can see everything that's relevant to your median nerve, and you can see the median nerve very well. Now, if you increase the depth so that this little structure right here is your median nerve, here are your muscles above and below the median nerve, here's your radius, here's your ulna, interosseous membrane, the dorsum of the forearm, and now you're starting to get artifact because you're seeing the table beneath this patient. You can barely see your median nerve, and you can see all this stuff that makes no difference to what you're interested in. So this person has too much depth. This is perfect. Then you want to adjust your focal zone so it lines up with the object of interest so that you have the highest resolution. So in this case, this is the focal zone depiction on this machine. So I have the focal zone lined up with the median nerve, and you can see the normal fascicular pattern of that median nerve. Now if I move that focal zone more superficially, like this, all of a sudden I can barely see that median nerve, even though these are the same pictures using the same resolution image, the same transducer. But since I've moved the focal zone, I've immediately reduced my ability to see that median nerve. So make sure that you line up your focal zone with the structure of interest. The gain is the overall brightness of your screen. And so here, this is the gain that I would like to see my median nerve, but if I turn up that gain, all of a sudden I've whitewashed my whole screen and I just can't see that median nerve. There's no perfect gain, you just have to see what looks good to your eye and adjust the gain accordingly. Now the time gain compensation is essentially a focal gain. So the knobs that are at the top of the screen right here are going to increase the brightness if you move to the right or decrease the brightness if you move to the left. And these correspond to the bottom of the screen. And the same thing, if you move it right, it's going to get brighter, and if you move it left, it's going to get darker. So you can adjust individual portions of the screen in order to improve your ability to see the structure of interest. Both of these are examples of incorrect use of time gain compensation. The time that I usually use time gain compensation is for deep structures. So remember, with attenuation of your sound signal, you're going to have a stronger reflection and more sound waves superficially, and as you get deeper, you're going to have less sound waves and therefore less reflection. So your image is going to tend to get darker and darker and darker as you look for a structure deeper and deeper and deeper. So if you move all of your time gain compensation a little bit over to the left, more superficially, in the middle, and then over to the right as it's deeper, then you're going to even out the overall gain of the entire screen so that you can see all of the structures that are interesting. Duplex ultrasound refers to a pulsed ultrasound machine that looks at the grayscale image first, so you see your normal gray image, but then it tacks on top of that the Doppler mode, which the Doppler mode looks for flow or motion. And since this can't occur simultaneously, you're stacking two images on top of each other. So similar to having multiple focal zones, when you are using duplex ultrasound and you're looking at your grayscale with an overlying Doppler image on top of it, you're going to slow your frame rate and your temporal resolution. There are several different types of Doppler. The first type is power Doppler, which uses a single color It is not angle dependent, so your sound wave can hit any moving structure below it at any angle, and it will detect that movement. And so it's very, very sensitive. However, since it can't tell you any flow characteristics, it's not very specific. It doesn't give you a lot of information about which direction it's going, what the velocity is, and so on. So this is really good for slow flow states because of the sensitivity, or small vessels and deep vessels. So it's great for neovascularization within a tendon, but it's not going to give you as much information if you're doing a true vascular study. That we usually use color Doppler. Color Doppler has two colors and it detects directional movement. In order to determine whether something is coming towards you or going away from you, it has to strike it at an angle other than being a right angle. And so it's angle dependent. If you have the transducer at a right angle relative to the movement, since it can't tell whether that movement is coming towards or going away from the transducer, it won't detect anything. So it's more specific and gives you more characteristics than power Doppler, but it's less sensitive. Spectral Doppler involves placing this trace over the area of flow that you're interested in, and it will detect some of the flow characteristics, and it provides an audible and visual waveform, so you can determine if something is arterial or venous or is associated with your vasculature at all. Another thing that you can do with knobology is the panoramic or extended field of view image. So if this is your Achilles tendon and you're doing a standard image, then you might only get this small area. But the pathology, which is a fairly large area here, you want to know where that pathology is relative to your distal image, and it's really nice to have the entire thing on one screen. So essentially you glide your transducer over the top of this, and the ultrasound machine will electronically add these echoes together and create a long image. Dual screen enables you to have two pictures on the same screen at once, and this is really nice for side-to-side comparisons. So here's a acromioclavicular joint that is sprained. You can see it's widened here with hypoechogenicity of the ligament, and this is the normal AC joint on the contralateral side. You can also do beam steering or trapezoidal imaging, and essentially you can do electronic phasing, similar to what I was talking about previously with focal zone creation, and you can change a linear array transducer into a curvilinear array or a trapezoidal image, and so it widens your field of view. Compound imaging is very, very important. So previously, all the sound waves in the original ultrasound machines all came straight down underneath the transducer. So this is just a depiction of sound waves based on a paperclip being underneath the transducer. Whereas if I place that same paperclip underneath a transducer that has compound imaging, the sound waves come out at multiple different angles. So you can see this fan of sound waves coming out. And what that does is it increases the likelihood that your sound wave is going to hit the tissue interface at a 90-degree angle, which increases your reflectivity and minimizes artifact. Also, if you have a structure in this area and it blocks some of the sound wave, if you have sound waves coming in at angles, you can actually see underneath that image or underneath that structure that was blocking sound waves previously, so it minimizes some of the posterior acoustic shadowing that can be seen on small objects. So it's very nice and improves your resolution. Compression has to do with what the number of colors of gray that you have on your grayscale. So if you, with compression, it's talking about the dynamic range, which is the number of colors of gray that you have on your grayscale. And so if you have an increased dynamic range, then you're going to have more shades of gray, and if you have a small dynamic range, you're going to have fewer shades of gray. So here we have a very large dynamic image, or dynamic range, and so you can see lots of smoothing out of this image and lots of grays. Here it's much more pixely because this has a much smaller dynamic range, so there are less colors of gray. Both of these have their advantages and disadvantages, and to some degree you have to look at what dynamic range looks best to your eye and then choose it accordingly. The dynamic range is adjusted by your compression, and compression is reported as a percentage of the dynamic range. As you're looking at an image, you can store multiple different frames at once, and you can stack those on top of each other, and that can smooth the image out and reduce some of the artifacts that are commonly associated with a single image. The problem with increasing, and this is called persistence, the problem with increasing your persistence is you're stacking more images on top of each other, and so it'll slow the frame rate. And again, that reduces your temporal resolution and can make it look like you're imaging things under a strobe light. So now we'll move into normal and abnormal images. And the first thing we'll talk about is skin, which is superficial. Skin is hyperechoic, uniform, and is the most superficial structure. Below that is going to be your subcutaneous fat, and it has mixed echogenicity. The hypoechoic areas are the fat tissue themselves, and the hyperechoic areas are the septa in the fat. It is very irregular. It is not susceptible to anisotropy. And here are some different abnormalities that you can see. This is an area where the fat has actually been broken by a sharp object, so this is a fat fracture. The area of the fracture is typically hypo or anechoic, and you'll have linear fat disruption. Another thing that you can see is a fat infarct. Fat infarcts typically are hyperechoic, so you can see here in the subcutaneous tissue this hyperechoic structure, and in the middle is going to be a hypoechoic region. Cellulitis occurs with abnormalities in the subcutaneous tissues. So you're going to see fluid within the subcutaneous tissues. So here you can see an area of cellulitis. Here is normal subcutaneous tissue. So it's going to have mixed echogenicity. You also often have hyperemia in the area. So here you can see hyperemia in those tissues. Another abnormality in the subcutaneous area is a Morel-Lavallée lesion. This occurs typically because of a large shearing force to the subcutaneous tissues, such as a motorcycle racer crashing and landing on their hip, and it creates this huge shear force across their subcutaneous tissue, and it delaminates the subcutaneous tissue off the underlying fascia that's covering the muscle. Often this is filled with anechoic tissue, but it can be tissue or fluid that's mixed echogenicity, such as hemorrhage. Lipomas are more complicated. These can be anywhere in the body, but the most common place is in the shoulder and upper extremity. They can be in the subcutaneous tissue, but they can also be in muscle or in tissue planes. They are often oval, they're soft and pliable, and they have little or no Doppler activity, and they can be iso, hypo, or hyperechoic. So this is a lipoma in the deltoid, and you can see how hyperechoic that is. And then this is a hypoechoic subcutaneous mass, again, in the deltoid region. So same region, totally different looking lipoma, but they're both lipomas. Below the subcutaneous tissue is the fascia, which is hyperechoic. It's homogeneous and sits on the surface of muscles. One abnormality that you might see is a muscle herniation. So here is fascia sitting on top of hypoechoic muscle. Here's fascia again. And here is a defect in the fascia with the muscle protruding up through that area. And you can enhance the ability to see this with dynamic imaging. Muscle is mixed echogenicity. The muscle fibers are going to be hypoechoic and fascicles. And then you're going to have hyperechoic fibroadipose septa and perimysium in between the two. So in a long axis, it's going to have a feather appearance or pinnate appearance. A lot of people will call this veins on a leaf. So here would be the stem of the leaf with all the veins coming down onto it. And it's very uniform and has nice architecture. In the short axis, since all these fibroadipose septa are somewhat random in the short axis, it gives it more of the Starry Night Van Gogh appearance. Again, the hypo and hyperechoic structure, so it's mixed echogenicity. Muscle has minimal susceptibility to anisotropy. From an abnormality standpoint, one of the things that you'll commonly see is a strain or a focal disruption of the muscle. And the most common place to see this is going to be at the musculotendinous junction. And these can be subtle, so you often want to compare side to side. So here you can see the medial head of the gastroc coming down, really nice pennate structure here, and then you can see focal disruption where it would be attaching to the aponeurosis. Whereas on the contralateral side, you can see everything attaching very nicely onto that aponeurosis, so it helps you to see when you do side-to-side comparison. Dynamic testing can also help you because you're going to have retraction of these fibers that have been torn off of the aponeurosis. You might have a defect. Sometimes you'll have a hematoma, and if it's more subacute or chronic, you might have associated calcifications, increased Doppler flow, and scar tissue formation. Another thing that you'll see in muscles with ultrasound, and it's very important to note, is atrophy. So atrophy will be a uniform, homogeneous, hyperechoic, and decrease in size of the muscle. So if you look at this, this is the teres minor in short axis, and the infraspinatus in short axis, and the supraspinatus. Look at the difference in this echo texture compared to down here in the teres minor. So mixed echogenicity, more hypo than hyperechoic, pretty homogeneous and all hyperechoic and decreased in size. You can also have contusions. Here is a quadriceps contusion affecting the vastus intermedius. In the acute setting, it's going to be complex fluid because of all the cellular elements, but as those become more organized, they're going to form septa and debris, and the fluid will separate out from the cellular component, and you'll have a less complex fluid. Over time, this can create myositis ossificans traumatica. So here you can see the femur, and here you can see calcifications again in the vastus intermedius, another calcification, and these are post-traumatic. Tendon is hyperechoic and fibrillar, and in the long axis it is sort of rope-like. So this is the flexor pollicis longus with muscle on either side, and you can see that tight, packed, fibrillar appearance of the tendon. In the short axis, it has a broom end appearance. Again, it's hyperechoic and fibrillar. Tendons are non-compressible. They should not typically have any vasculature on Doppler imaging, and they don't branch in general. They don't tend to change in terms of their depth. So they're not starting more deep and then becoming more superficial. They stay at the tissue depth that they start at. And they attach muscle to bone. They are very susceptible to anisotropy. So now I'm going to talk about anisotropy, this artifact I've been referring to for quite some time. It's a really common artifact, and it's one of the main pitfalls with ultrasound. So it's very, very important to be aware of. It can cause a false positive. So when you have your transducer perpendicular to your structure of interest, you're going to get that specular reflection I was talking about before. So in a tendon, you're going to see that fibrillar appearance. Whereas if the sound wave hits the structure of interest at an angle, a lot of the sound wave that reflects is going to reflect into the distance. Since it reflects away from the transducer doesn't even know there was a structure there, and so that area is going to be hypo or anechoic because it doesn't detect anything. So if you look at this, this is just wagging the transducer over the top of the carpal tunnel. Here are all the tendons of the carpal tunnel, and as I wag the transducer, you can see how those tendons disappear and reappear. So that just depends on whether your transducer is at a right angle relative to the tendons or at a different angle relative to the tendons. Tendons are the most susceptible to anisotropy, followed by ligaments, followed by nerves. So this is very, very important. So abnormalities in tendons, one of the most common things you'll see is tendinopathy. So you'll see a thickened, hypoechoic, heterogeneous region of the tendon. You might see calcifications in the area or Doppler. Here's significant Doppler flow in an Achilles tendon with Achilles tendinopathy. Now that needs to be differentiated from tenosynovitis, where you have inflammation of the tendon sheath in the synovial lining. So you're going to see thickening and hypoechogenicity of that tendon sheath along with hyperemia. But inside of that tendon sheath, usually the tendon is going to look relatively normal. Tears can be partial thickness, and that can be on the surface of the tendon or on the deep surface of the tendon or in the mid-substance of the tendon. And it's going to be a partial fiber disruption. In that area, you'll have typically an anechoic cleft or defect. You'll often have volume loss. Whereas a full thickness tear, you're going to have complete absence of the tendon fibers with a gap in the area. So here is a full thickness tear of the supraspinatus in one focal region. It will often be anechoic, although it may be filled with debris or other structures, which can fool you into thinking that it's not a full thickness tear. So some of the things you can do to help you evaluate a full thickness tear are dynamic imaging. So here's an Achilles tendon with one end here and another end here, and moving the ankle from a dorsiflexed to plantar flexed position. So you can see the two ends approximating each other. This is a normal flexor digitorum superficialis and profundus tendon going from distal to proximal across the mid portion of the palm. Here you can see the flexor digitorum superficialis intact, but right there you can see the flexor digitorum profundus has been torn, and there's just a stump end right in that area. So the dynamic imaging helps you identify that torn tendon end. Now, I was talking before about the fact that anisotropy is an artifact that can cause false positives. So you need to differentiate anisotropy from a tear. And in order to do this, you need to manipulate your transducer. So what you'll see if your transducer is at this angle and you're looking at the insertion of your rotator cuff, and this is just an MRI, some of those fibers are going to be coming in at a curve, and so that is anisotropy, but that looks a whole lot like a partial thickness articular surface tear of the supraspinatus, and that's the most common tear of the rotator cuff, and also one of the most difficult to detect. But if you just move your transducer a little bit, so doing a heel-toe maneuver, look at how that fills in. That's the exact same supraspinatus tendon, and now you can see all of those tendon fibers. So what I was looking at before was not a tear, it was actually anisotropy. So make sure that you manipulate the transducer to eliminate anisotropy. You also want to image any area of pathology in orthogonal planes, so long axis and short axis. And you can also use edge shadowing, which I'll talk about in a little bit, to help you determine whether something has a significant tear or not. The next structure of interest is going to be a bursa, which is a potential space. It typically is a hypoechoic or anechoic line that has a peribursal hyperechoic region, which is the peribursal fat. Abnormal bursas or bursitis can have synovial hypertrophy. So here you can see this granular thickening of the bursa that is typically hyperechoic but can be hypoechoic. Or it can be filled with fluid. And that fluid can be either simple, like in this picture, or it can be complex. The bursas, when they do have fluid, are going to be very compressible, so you need to make sure that you lightly float the transducer over the area so you don't compress the fluid out of the area. The other thing is that you can't differentiate infection from just an inflammatory bursopathy. And so if you have any suspicion that the fluid inside of a bursa is infected, then send it off for cultures and sensitivity. The next structure of interest is a ligament. Ligaments are fibrillar, similar to a tendon, but not quite as fibrillar as a tendon. They can be hyper or hypoechoic, and it just depends on where they are relative to other structures. So this is the medial collateral ligament, and you can see how that's hypoechoic, whereas the ulnar collateral ligament to the elbow is hyperechoic. They are, again, non-vascular as far as being able to image vascularity, and they have moderate susceptibility to anisotropy. They connect bone to bone. When you sprain a ligament, you're going to have similar findings to tendon injuries. So these can be partial thickness tearing, such as this picture where you have the proximal MCL, very thickened, hypoechoic and heterogeneous. It no longer has its fibrillar appearance. It might have hyperemia or calcifications in the area, or a full thickness tear. So here is the anterior inferior tibiofibular ligament intact, And over in this area, you can see complete disruption of those fibers. Dynamic testing can really help you assess the integrity of the ligament. So this picture is of the ulnar collateral ligament. So here's the lateral epicondyle coming down to the capitellum and the radius, and coming down to the trochlea and the ulna, and over the top of it is your ulnar collateral ligament. And if I do a valgus stress to the elbow, you can see how this area opens, and it'll open even more on this second stress, and that shows disruption of that ulnar collateral ligament. Another thing that you can look at is cortical bone, and because of the significant difference in the acoustic impedance between the overlying tissues and the bone, you're going to have significant reflectivity in that area, and so it's going to be very, very hyperechoic. Below it, since no sound waves are going to penetrate it, you're going to have posterior acoustic shadowing, which is a common artifact below calcifications. So one thing that you can see with ultrasound in bones are fractures, where you'll see cortical disruptions. Right here, you can see cortical disruption from a humeral head fracture. Another thing that you can look at are periarticular erosions in somebody with rheumatologic disorders. And you can look at the synovitis in that area, and if they have active Doppler in the area, it's active synovitis, whereas if they don't have active Doppler, then it's inactive. The bone erosions occur at the articular cartilage interface with the bone in the periarticular region, so it's not under the cartilage, it's next to the cartilage. And it's indicative of an inflammatory arthropathy. If it's active, it's hyperemic, and if it's inactive, there's no hyperemia. You can also look for effusions. So this is the suprapatellar recess with a large effusion in the area, and that is intra-articular fluid. It can be either anechoic or hypoechoic, or it can have mixed echogenicity depending on whether it's a hemorrhage or traumatic or inflammatory or infectious or simple. It's going to be compressible. You might have hyperemia in the synovium if you have synovitis associated with it, and occasionally you might have loose bodies in that area. Articular cartilage or hyaline cartilage is going to be hypo or anechoic. So here you can see the hyaline cartilage of the trochlea in your knee. It's going to have uniform thickness in somebody who doesn't have osteoarthritis, and it's going to be non-compressible, and that's one of the ways you can differentiate it from fluid within the joint. An osteochondral defect, you're going to see a defect in that cartilage. So in this area, you're going to have normal cartilage of the lateral femoral condyle. Here's the patella, here's the femur, that lateral femoral condyle, and you can see the articular cartilage over it. Here's the medial femoral condyle, and right here you can see an osteochondral defect in that area. Fibrocartilage, such as your medial meniscus or in the acromioclavicular joint, is typically going to be hyperechoic, granular in nature, and uniform. Whereas if you have pathology, such as somebody who has a medial meniscal tear, then you're going to see a hypo or anechoic cleft. It's going to be heterogeneous, so here you can see the tear in that medial meniscus. Or it can be fully collapsed, and you might see periarticular bony changes, such as hypertrophic osteophytes from somebody who has osteoarthritis. You may also see periarticular cysts. Here's somebody who has an AC joint that's significantly arthritic, and you can see a cyst all the way over in this area with the pedicle of the cyst coming back to the AC joint in that area. So while ultrasound can see these fibrocartilaginous structures, it can't usually evaluate the entire thing, and so when you see pathology, you definitely see it, so it has high specificity, but since you cannot look at the entire structure, it has lower sensitivity. Nerves are mixed echogenicity, and in the short axis, they have a fascicular or honeycomb type of appearance, or often called follicular, sorry, not fascicular, but follicular. In the long axis, again, they have a fascicular appearance. It's striated. They are going to be deformable, but not compressible. And what that means is when you push on a nerve, the nerve doesn't disappear, but it might deform, whereas something that's compressible will disappear. They're not very susceptible to anisotropy, and they travel with vessels, and that's one of the ways you can help differentiate between nerves and tendons. Another thing is that, like I said before, tendons don't branch, but nerves branch. As you're going distally, the nerves are going to have arboration, and so they're going to branch just like a tree. Nerves tend to be mobile, so here's the median nerve, and I'm just having this patient move their flexor tendons, and so you can see it bouncing around in that area. And they often change position. So here's the median nerve. It's deep. It's in between a bunch of muscles, but now it's crawling all the way up on top of all of these muscles, so it's changed position while going from a proximal to distal location. From an abnormal standpoint, one of the things that you'll frequently see is entrapment. And in that case, you'll see focal caliber change. So you'll see stenosis at the site of entrapment. So this is the median nerve. Right here is the transverse carpal ligament over the top of it. Right here is the area that it's compressed, and so before that, it's going to be enlarged, and at the site of entrapment, it's going to be compressed. And when you look at it in short axis, you'll often lose that fascicular pattern. So here it's fascicular, here it's just big and hypoechoic. So it loses its internal architecture. Occasionally you can also see hyperemia in the area, so increased vascularity, but that's not very common. Another thing that you can see with nerves is instability. So here's the ulnar nerve with the medial epicondyle, and here you can see the nerve dislocating in and out of the retrocondylar groove. Vasculature is going to be anechoic when Doppler is not on, so here you can see no Doppler, it's anechoic, it'll be circular. Arteries have a thicker wall and are going to be pulsatile and less compressible, whereas veins are very compressible. So here you can see the artery and here are the veins. And with minimal compression, the veins go away and the artery stays in that area. So if you want to see veins, you have to remember to float your transducer with gel and really minimize the amount of compression. Finishing up here, I'm going to talk about a few more artifacts. So reverberation artifact is where a flat, very reflective surface sends a whole bunch of sound waves back up to your transducer. But since your transducer is also flat, some of the sound waves are going to reflect back down again, and you're going to get this back and forth reverberation of sound waves, which is going to create these echoes down lower that make it look like there are multiple needles down below the needle at the top. So this is reverberation artifact. It's common with metal. Posterior acoustic shadowing is a hypo or anechoic region below an area that has high reflectivity, like calcifications. So this is common below calcifications, but also below scar tissue and septa. So here you have the anterior head of the deltoid, the middle head of the deltoid, and the intermuscular septum between the two. And below that septum, if you watch here, you're going to see a little bit of refraction artifact, or excuse me, posterior acoustic shadowing as you go back and forth with that septa. And that can mimic and make the tendon below it look like tendinopathy, or that it has tendinopathy in it. And so you just have to realize that that is an artifact and not tendinopathy in the area. Another thing that you can have is posterior acoustic enhancement. So in this case, you have an area that is not absorbing sound waves, and so more sound waves are coming through that area than through adjacent tissues where you have normal sound wave attenuation. So the tissues adjacent to it are going to be darker than the area where you have these unattenuated sound waves going through the structure. These are usually associated with cystic lesions, but they can be with solid lesions too, so don't let that fool you. Mirror image artifact is another form of a reverberation artifact where you essentially have the image up here and you end up with a mirror image exactly below it from that reverberation that I was talking about previously. This requires a strong reflector, so it's frequently seen around the diaphragm and pleura, and it can be enhanced by through transmission. Refraction artifact is going to be around curved surfaces, and so essentially remember when I was talking about the angle of incidence, if your angle of incidence is not at a right angle and it's at an edge, then some of the sound wave that transmits through is going to be refracted. And the refraction is going to cause a posterior acoustic shadow. So here is a disrupted Achilles tendon, the more distal and the more proximal aspects, and you can see a refraction artifact at the end of those tendons. It can obstruct the views deep to the structure, but it can also help you find the end of the structure, so it can be helpful. So in conclusion, in order to maximize the diagnostic utility of sports ultrasound, you have to have a basic understanding of ultrasound physics. You have to select the right transducer, hold it correctly, identify the structures of interest, and manipulate the transducer to optimize the image. Then use appropriate knobology. And then when you're looking at it, you have to know what it should normally look like. So you have to have a knowledge of the normal appearance of structures and also the pathologic appearance of structures so that you can diagnose abnormalities. You also have to recognize and minimize common artifacts in order to minimize your false positives. Thank you very much for your attention, and here's the bibliography for this presentation.